So welcome everybody who is on this Zoom call. I have the pleasure of introducing three faculty who are amazing. First, we have Elaine C2 Lacasse, who's the Director of Ultrasound Education at the University of Arizona in Tucson. And then Dr. Michael Gottlieb, who is the Ultrasound Director and Fellowship Director at Rush in Chicago. And then we have Teresa Liu, who is co-director of the Ultrasound Fellowship at UCLA. And they're going to be talking about something that anybody who's interested in ultrasound and teaches ultrasound has been very challenged during this pandemic. So they have lots to say about it. And hopefully we can allow time for the chat, because I'm sure many of you will have questions and kind of other things to share to the conversation. So thank you all.
So I'm going to go ahead and start us off. Thank you everyone for joining us today on how to deliver high quality ultrasound education during a pandemic. And thank you so much, Lynn, for introducing us. And in addition to myself, I have Mike and Teresa, and I will start us off with talking about some asynchronous educational resources. And Mike will then transition into teaching ultrasound during the pandemic. And lastly, we have Teresa, who will talk about how the pandemic has transformed how we deliver education, and will contemplate future directions. At the very end, we'd like to welcome any questions and also sharing of tips and lessons learned over the course of this past year. So we'd really like to have audience participation in that part. So conflicts of interest: I'm a funded scholar of the National Foundation of Emergency Medicine, and Mike reports grants from the Centers for Disease Control and Prevention, Council of Residency Directors in Emergency Medicine, and Society for Academic Emergency Medicine. And Teresa is a paid consultant of the Center for Medical Education. And also, just a broad disclaimer, we will be talking about educational resources with brand names and equipment. We do not explicitly endorse any of them. So over the course of this past year, the pandemic has really inspired the point of care ultrasound education community to put out a lot of asynchronous resources, from developed curricula to more gamification resources to quizzes. We have seen a lot of things pop up. So there are open access resources and also paid courses for purchase. The open access items include heavily vetted curricula created by point of care ultrasound educators and experts from around the country for medical students, for residents, for fellows, and of course, ebooks that are available. And for the courses that are for a fee, they tend to be educational modules that are a la carte. So this could potentially be cost prohibitive for our novice learners of medical students and residents. For faculty members or potentially fellows, if there's CME money available, that's something that can be explored. If the institution purchases these modules, then of course the accessibility increases. One of the best resources that I've seen thus far is this paper in AEM Education and Training by Panebianco et al., Joint Recommendations and Resources for Clinical Ultrasound Education Amidst the COVID-19 Era. And there's the QR code to take you to the paper. But I also strongly recommend the appendix. In there, there's a list of resources with hyperlinks that will take you to those websites. And it's divided into free and paid resources, and also for which type of learner it is most suitable, whether it's novice, intermediate, or expert. So I highly recommend this. So with so many things coming out every single day, how do we keep up with the new materials that are out there? And one of the things that we recommend is first looking to our POCUS communities. This is the newly revamped AEUS website. On there, you can see links to free resources. The narrated lecture series took a lot of person hours to curate, to edit, to make sure that everything in there is up to date. And it could be easily accessible by all of your learners. And as long as you're an SEM member, you can join AEUS for free. So I recommend that not only for education resources, but also just to keep up with what's going on in our community. This is the page for the ASAP emergency ultrasound section, the education and training page. Of course, there's the emergency ultrasound management course that's been very popular, great for fellows, of course, and also faculty members looking to start their own programs, but that is for a fee. The online education that's free, one of the newest things that's coming out is the revamping of the Sono Guide. So Dr. Deja Eisner and Dr. Gabe Rose out of San Diego, they are working tirelessly to bring you the updated chapters. So it is still a bit of a work in progress. There's a lot of good material that's been posted already, so keep your eye open for the finished product. Many of you may already know this, Google Foam Search. So this is a search engine that searches through, makes a unified search of the foam that's out there. You can search for emergency medicine, point of care ultrasound. And if you do a search, I did a search of point of care ultrasound here, every listing, every result has a label. And what it does here it tells you that 61% of the search results are labeled with journals, 25 EM critical care, and 5% just ultrasound. So if you clicked on these hyperlinks, it'll take you to a list of results that are just labeled journals or just labeled EM critical care or ultrasound. Not only is this a great resource for learners, but also for educators trying to look for high quality materials to add into their repertoire. Also for Foam Ed creators, you can email the creator of this Google Foam and he can add your resource into one of the search results. So that is very helpful. Now we're going to take a few minutes to talk about how to evaluate all of these online resources out there. How do we know which one is high quality and is worthwhile passing on to our learners? One of the more common rubrics is the R-metric score. It's broken up into 3 different categories of questions to ask yourself when reading something: content, credibility, review. It's 7 questions, and on this rubric of 0 to 3 points, the higher the point value you assign to a particular piece or a resource, the higher quality it is. And of course, if you're looking at point of care ultrasound resources, then just keep that in mind as you're reading through these questions. And you all may have also seen this, the ALIEM's AIR scoring instrument. AIR stands for Approved Instructional Resources. It's broken into 5 categories of questions: the BEEM rater scale, that's the best evidence in emergency medicine, then content accuracy, educational utility, evidence-based medicine, and referencing. And it's the rubric of 1 to 7, 7 being the highest, of course. And the higher the score, the higher the quality. And for the highest rated resources that are out there, ALIEM actually gives it the AIR certification. And those resources can also be found on the ALIEM's website. There are also quality checklists for professions, for health professions, blogs and podcasts. I won't go into that much here, but this QR code links you to a website called the Winnower, and it does a really good job of going over this paper, and it includes graphics on the quality checklists. So definitely check that out if you're interested in that. And with that, I will hand it over to Mike, who will talk about hands-on teaching.
Thanks, Elaine. So Elaine did a really good job here of highlighting out resources for asynchronous learning. And I think this will be helpful even post-pandemic. There's a lot of times that we're doing things that are duplicate work of each other. We're doing things that are wasted efforts because they already exist, or multiple people are simultaneously doing things. And so I want to sit here and focus through some of the ways that we can take this to the next step of not just asynchronous, but how do we advance our synchronous learning, building off lessons learned from the pandemic, and also to adapt to the current pandemic. And if we end up in a situation where, again, in-person learning may not be possible. So in essence, how do we teach ultrasound when we can't be there in person? And let's begin with lectures. So traditionally, when we think about didactics, and this has changed a lot over the past year, we imagined that a speaker would come out and you either have a speaker from your program or some surrounding program that was in close proximity. But now, as we see with Zoom, we can bring people into our classrooms, into our lecture halls pretty easily and pretty simply. We can run virtual grand rounds, capitalizing on people who have expertise in specific areas. This is an example where Jefferson's program, they have their monthly kind of guest educator who can bring a content expertise in the case of pediatric POCUS or education research or whatever arena. And they get, on their end, it's easier because they're talking about things they already know. And on the recipient side, you actually get to now benefit from the specific targeted expertise. And in fact, a group out of Jefferson studied this. They looked at this among residency grand rounds, and they compared before and after COVID, what was the impact on finances? And not surprisingly, it was less expensive. You don't have to pay for travel costs and housing costs. It's much easier to bring someone in via Zoom than when you used to have to fly someone out to give grand rounds. And if we take this in the ultrasound community, well, I don't know about you, but I'm not flying anyone for ultrasound grand rounds amongst our smaller group of faculty. I'm not getting any likelihood of that happening. So before that, what was happening is people were doing for free. They'd have to, if they wanted to come out, they have to fly out or find some way to get there. And as junior faculty, who are the groups that more commonly are doing this, that's a lot of cost on them individually to give these talks. If we look at the virtual era, just the ability to kind of bring people in there, it's a great opportunity for junior faculty as well to be able to speak and get some experience giving talks without the cost associated with having to fly out. Now, a similar model of this can be used for journal clubs. Again, we think about pre-COVID when we used to all get together for journal clubs, everyone had to be in the same room. There's a lot of parts I miss of that aspect of it. But when we think about journal clubs, it's often still our same core group. Everyone gets together and now they're over Zoom and it's the same people talking through it. And that's great because you have a lot of really highly qualified faculty with a lot of expertise, but it's still just a smaller group. I think there's an opportunity here to really expand out our horizons and connect in with people wider and broader. This is an example of at AEUS when they had a much broader journal club, but everyone got together to talk about the future of ultrasound within COVID-19 research. And I think it extends beyond just that. When you're at your institution, being able to get insights into maybe I can have someone that's an expert in certain methodologies. I may not have a systematic review expert or a randomized controlled trial expert at my institution, but I could bring someone who could bring some really good expertise in methodology, maybe a content expert to talk about airway or musculoskeletal or some of the more advanced applications that I may not have a clear expert here. Or if we're going over an article, maybe we could bring in the author to actually discuss it with them, get their insights. I'm always happy to share all the fails that happen to get to the final publication, all the things I've learned along the way. And I think that that's a real great opportunity to see kind of behind the curtain of what the paper that is the end product of how they actually kind of got there, right? What were all the challenges to get there? I think that's a really cool opportunity. And I'm sure a lot of people would love to just talk through their paper in a little bit more depth and to really hopefully advance our field and help us to learn from each other and some of our mistakes. Now, one other really cool way that came out about half a year ago now was looking at the role of Slack or different types of messaging type programs. So Slack is the real-time discussion software that allows you to have these kind of threaded conversations and connect with other people. And what they did, a group out of Wayne State, they looked at how to use Slack to help teach imaging. Now, this was a little bit broader. It wasn't just ultrasound. They used CTs and X-rays and other types. But they found that over an 8-month span, using Slack to engage each other, that residents had more confidence with their ability to interpret imaging. And 3/4 were viewing these almost as frequently as they came out. So as soon as a new piece of information came out, they were reading, engaging, interactive with this in a way that allows a lot more back and forth than traditional didactics or just sending an email. And if we look at, there's a cool image I have on the next slide from how they were actually using Slack. And you can see, here's one where they had a great case. They threw the CT cropped out to keep it HIPAA compliant. And they said, what do you see? What do you think? What should we do about this? To help actually start to try to apply this into practice. And I can imagine the same thing for ultrasound. Here's a cool case. They threw it up in Slack. You could actually pretty quickly convert it to a GIF or save an image or whatever is useful there. You can upload videos. Depending on your software, a lot of them allow you to remove the identifiers right away, so you could put it into there. Although higher level Slack is HIPAA compliant. And even from there, you can imagine engaging some conversations about this, helping us to make this a little bit more real time. Or you know what? I had a really tough ultrasound. I'm not sure what to make of this. You put it in a Slack, and everyone in the ultrasound division or everyone in the residency can respond and give feedback and say, oh, I see where the issue is, or here, you know, that actually I probably would interpret this as a positive fast, and here's why. And you can get that real-time feedback on something you just did in the clinical environment. So I think there's a lot of ways that we can take software that's out there and apply it new for ultrasound. Another technology, another approach that's been out there is the idea of POCUS Jeopardy. And I know a lot of institutions are doing things like this. It's just gamification. It's how do I step away from just a lecture where someone's talking at me? How do I engage people more? And we're going to talk about a few other strategies shortly, but one of them is to just make it a game. Use Jeopardy, engage people, ask them questions, make it a little bit team-based, bring out the type A competitiveness that we all kind of hide, and bring it to the surface and let's everyone try to figure out and prove that we are the most savvy with ultrasound. And as a result, learn more. Now on the bottom right, you'll see a QR code. That's a link to the one from the POCUS Atlas, which is freely available. So you don't even have to create this yourself. Again, one of the themes here is avoiding reinventing the wheel. Take things that are already there, bring it to your shop. You're all so busy. Try to avoid having to recreate things that are already there. Another strategy I like was this idea, with this group out of UCLA, looked at the ultrasound treasure hunt. And the idea here, again, goes back to the gamification. We have residents at this time who were not able to scan in person. So how do we engage them in learning? How do we make sure that they're doing this? They would actually have them do these ultrasound treasure hunts. And on the next slide, you'll see kind of an example of what this looks like. And they would assign them, okay, so for example, this one is starting with a fast. How do I get that right upper quadrant? So step one, save an image of the liver tip with adjacent bile gas. Step two, now you're gonna move posteriorly and image the Morris pouch. Step three, get the liver tip. And so this is something that we would talk someone through, but now we found a way to make it a little bit more of a game to show, yeah, you get that image. They would go home with probes and they would obtain these and then upload them. And again, to make things easier for you, that group put out a whole list of everything they did of the full kind of treasure map, which is hyperlinked again in the left corner with that QR code. They have it for thoracic, they have it for fast, they have it for aorta, for renal, MSK, ocular, echo, DVT, gallbladder, almost every application you can think of, they built that out. So you can use what they've already started, or you can model it and make your own, depending on what your priorities and what you want people to learn from are. But again, we could take that, you could send someone home with a probe, and a lot of this is automated. So it's not on you doing direct one-to-one teaching. You can actually give follow-up after they scan a little bit on their own. Another area that I've found particularly well suited for this, Zoom virtual environment is QA. Let's reflect back in at least my experience of when I was a fellow and when I was a resident, you did QAs. We all sat in this room. The rooms would get really, lower down the lights. You had the one big screen or smaller screen. Sometimes you're huddled around a computer, back looking huddled shoulder to shoulder, and you'd all be sitting there watching it. And one person will go through this QA, and that's fine. That gets everyone together, but that means a lot of times people are coming on their days off to do this. It means that we're all kind of getting together in a time where we can't really huddle the same way, and probably doesn't have to be that way. I can share a screen just like we're sharing a screen now and show images. Especially if you with programs like Zoom and WebEx, you can actually share this and review the QA in real time. You can have the whole group kind of join in. And there's a cool feature on Zoom. On the next slide, we'll highlight up there called Annotate, which if you haven't used it before, it's wonderful. It basically allows you to annotate or write on the screen. You grant everyone access so they can annotate structures or identify a pathology on the screen. And the next one you'll see, when you highlight that annotate button, you can select things, for example, like an X. So now if I'm the end user, I can make a red X on whatever structure you tell me to. So if I'm, let's say, going through QA with one of our medical students and we're saying, all right, let's go through a little MSK. This is a great image. How do I find the quadriceps tendon? Can you show it to me? And then they put an X on the screen. And I can say, yeah, that's it. Or if their X is in the wrong spot, they can delete it. I can put an X in the correct spot and show them in real time without actually being at the bedside. I could have them show me the patella, maybe the femur, maybe if there's an effusion, they could show me that. And we can go through our images, they can actually mark the screen real time so I can see exactly what they're seeing, but without actually having to meet in person. And then everyone else can see what they're seeing instead of them having to run up to the monitor and point and touch, on the monitor. Everyone can see exactly where we're at. So I think it's another really great opportunity to utilize software that we already have to reduce the amount of times that we have to be in person unnecessarily, but also to make it more convenient for people. How nice is it to sit comfortably at home and do QA as opposed to everyone having to go in the hospital on days off to do it? One other way I've used Zoom is to have the learners kind of predict the hand movements. I started doing this clinically too, but I find this particularly useful in Zoom, is I'll put up an image that's not perfect, one that has areas for improvement. And we'll go through it and I'll say, all right, so let's look at this image. So we're looking at what, so the typical way we do it, like, what image are you seeing? What chambers do you see, et cetera. But then once they identify an apical 4, I say, all right, cool. So if you had the probe in your hand, what would you do to improve it? And a lot of the learners sometimes will take like their cell phone or like a remote control or something to kind of model what they want to do. And be like, all right, so what do you think you need to do? And then we'd say like, oh, the septum's to the right. So I need to slide the probe laterally. The heart's to the side. So I need to, kind of rock the probe laterally. Maybe I need to fan to open the atria. And these movements that normally you have to be in person to do, you can have them start to hypothesize this and add on this without even having the ultrasound probe there. So I think there's a lot of opportunities, again, where we have things that exist, where we can expand our reach of it from the comfort of our own homes. That said, ultrasound is a hands-on skill. It's always going to be a hands-on skill. And no matter how much we talk theoretically about it, you got to get your hands on the probe. So there's a few ways to do that. One is if you have, the resources, if you have funding for it, having, at least 1 or 2 handheld probes that people could take on rotation, like Butterfly, V-Scan, or any other type of handheld that they can bring home and start to practice themselves, on family, and on, pets, on anything that's around there to look at, scan through, different objects. You can have them maybe practice how to be comfortable, like holding the probe with their pinky as they're kind of imaging things in water. There's a lot of things we have at home to allow us to at least get some of the hands-on. And yes, if they're scanning their own heart multiple times, they're not getting the versatility of seeing multiple things, but they're at least getting some hands-on, seeing how they react to different things. And maybe they can lay on their left side and their right side to make it easier and more difficult. They could try doing it with like big breaths and an exhale and inhale, and try things to try to move the heart around to just create a little bit more artificial, challenges of that. You can even have them, use some phantoms. If you have phantoms, send them home with it. And if not, you can actually walk them through how to do it. On the left bottom, again, is a QR code. And if you look at that, it's got a list of a whole bunch of homemade phantoms that are cheap, easy to do, that you could just show them how to make it. In this left case, you buy Spam and like a little piece of plastic tubing. It's like $5 easily. You can have that for home. So it's a lot of things that are really easy phantoms they can use to bring home so that they don't have to worry about, trying to transfer phantoms back and forth. One other option is ultrasound simulators. So there's a number of these all-in-one simulators that you can basically take home and again, start practicing on how to get these images. We actually started this during COVID-19 and then carried this forward even afterwards, really with the idea that, there's no matter how good the rotation is, no matter how much versatility of scans and diversity of scans there are, you can't see everything. We're not going to have a pericardial tamponade, hopefully, every single week. So that means that you won't see some of these things. The only way to get that 3D view, we found that the simulators were helpful for that. So we ended up carrying it even forward, but if not, it's a way to get comfortable with some of the hands-on dexterity. And then finally, some of the probes or some of the newer software actually has tele-ultrasound. And so you could theoretically have the person scanning, and you could, through tele-ultrasound, actually guide them through the process and say, here's how I would adjust the probe. I see how you got there. Here's how I modify it. And again, some of these probes, a lot of these companies have this for free or for limited costs associated with it. So you could take advantage of that as a way to be in the room with them, whether they're at home scanning, or if it's a COVID patient, maybe one person is in the room and everyone else can watch from afar. So a lot of people would be engaged with reducing the amount of exposure. And now I'll pass along to Teresa.
Thanks, guys. So my portion of the talk is more like, okay, now what? We've did a lot to adapt to the pandemic, and now the cases are dropping in most part of the country. What do we have to look forward to in the future? So I think there's 3 possibilities. Behind door number 1, we can go back to last year, which I hope we won't. But it's possible, depending on the kind of mutation and what there's a lot of different factors that go into it. So we have to consider that possibility. And I'm very happy I'm in California and our cases are dropping, and I'm hoping that that's the last of last year and I will never have to see last year again. Behind door number 2, we're going to say, okay, well, maybe we're back to normal. Are we back to normal right now? And can we really get back to normal? I mean, the reality is the genie is out of the bag, right? Even our new normal is not going to be the same as 2019 and before. And how do we adjust to that? What is our new normal? And then behind door number 3 is really the unknown. There's like maybe new pandemics coming. I mean, the world is changing in a way that makes it easier. Maybe there are other things that are changing that's beyond a pandemic, and which we'll think about and talk about a little bit, because I feel like a lot of times we are very reactionary to what's happening to us, like, you know, be it like technological advances or other things. But I think we have to really start thinking about this right now and be more proactive about how we're going to adjust to tomorrow today. So, you know, next slide, please. So based on what we endure through the past, year plus, there's some very easy lessons that, I think we can intuitively get. And if not, Elaine and Mike has spelled it out for you guys. So some easy lessons, like things that easily adapt to or can be pandemified in the future, or like things that we say, why didn't we do this before, is make the grand rounds virtual, make the QAs virtual, make the journal clubs virtual, right? I mean, there's like what we gain for doing in-person meetings for these events. Maybe we want to do it once in a while just for the social aspect, for team building aspect. But as the video conferencing gets easier, more intuitive, and we're just used to it, maybe we're replacing that. Just kind of like in other aspects of our life, social media have replaced some aspects of our in-person socialization for future generations and current generations and whatnot. And I work at a county hospital. Cheaper grand rounds, yes, please. QA, as Mike said, like actually I find that a lot of these meetings, the attendance goes up because you give people the flexibility to attend without the burden of commuting. I live in LA, again, the worst traffic areas are all around me. I would hate to have to drive an hour just to, go read some journal in front of 10 people, right? To be able to virtually invite the authors, the content expert. These are all things that were like, yes, let's do that way. And thank you, pandemic, for showing me the way, forcing me to take this leap, and I'm not going back. There's some things that we're like a little hesitant, right? We're like, okay, no, I mean, there's still things that maybe we should have in-person components, definitely, maybe a hybrid, maybe a little virtual, a little hybrid. And these are like the hands-on that we're talking about. Is teleguidance really as good or as efficient and a way of teaching scanning as in person? Somebody's got to do research on that. What about assessment? You can say, okay, well, show me the pictures, but there are a lot of intangibles, such as did the patient, did the learner go in and turn off the light, raise the stretcher, clean, wash their hands after the teleguidance? Did they make the patient comfortable, wipe off the gel? Did they charge the machine? Did they wipe off the probes? All these things, that we would normally put on our OSCE, we would not be able to observe just with pure virtual platform. So there are things that we were like, okay, we'll adapt some of it and maybe offload some of the in-person education to virtual, but there are things that just cannot be replaced. I talked to some salespeople recently, and we're like, don't you love not being able to fly, like not having to fly all the time? And they're like, yes, most of the times there are things that can be replaced, but sometimes you just need to go in and shake that person's hand, and there is that intangible that is really valuable to just kind of face-to-face interaction. So I think we learned that as well. So these are easy lessons, but we have to think about some of the harder questions that are not so obvious. And maybe because of the pandemic, now we are forced to really consider this. Like they bring these issues now front and center in our minds. And there, you know, and I kind of put these bullet points in a jumble up order. I want to talk about educational scans first, because this is the topic that has been troubling me for a while, for years, really. There's just something, you know, like that seems to be missing about the discussion of how we conduct our education, that now I think we can really talk about them, think about them, and come up with better solutions on how we provide quality education. And one of them is educational scan. When I think about educational scan, you have, or any teaching modality, you have to weight the negative or the risks against the positive, right? And so what are potential negatives of educational scan? Well, let's see, we're supposed to do POCUS and we're supposed to practice ALARA. We're supposed to expose patients to as minimum amount of ultrasound as possible, right? So now I have somebody who bumped his toe waiting for the x-ray, and now he got pan scanned by ultrasound. He's slick from eyelid to toenails, right? And how do you apply ALARA to this patient? Right? He gets no benefit from this scan, really, right? And then what about consent, right? Do patients truly understand what they're getting into? When you think about consent in the way that we do consent with everything else, with research, with putting in central lines or other invasive procedures and whatnot, do they truly get that consent when we ask them? And I've seen trainees and probably myself not being as careful as educating the patient about their consent to allow us to provide this educational scan. What about the power differential? Right? I see a lot of undocumented immigrants. I see a lot of them with English barriers, and they are in pain. They come here for us for help. Even a medical student, even a first-year medical student, they put on the short white coat, they got power over these patients. And they're going over there and say, oh, can I scan your body? And, you know, like, it's very easy to see that it may not be as well done in terms of this consent part as we theoretically think that we do. But this is bread and butter for us for the past decades. You know, ever since I was a resident, I remembering, okay, you know, you want to learn ultrasound, you go to some patient who look bored, or, you know, sometimes they say do a therapeutic scan on people who might be perceived as a little bit more needy, you know, and do that. Like, I mean, what are we really doing? We're doing this this educational scan, really, is there truly no risk to the patient? So now we talk about risk, let's talk about benefit. What's the benefit of educational scan? Well, it teaches you how to scan. So that's technique, technical skills. Technical skills are not higher learning. It's really like basic learning, right? And why is it not higher learning? Because if the patient came in for a bumped toe and you're scanning his aorta, there's no clinical integration. We're not teaching clinical decision-making. We're not teaching whether it's appropriate to use this particular diagnostic test. We're just literally using them as phantoms. So then why not use phantoms? Okay, well, you might say, well, learners need to be exposed to different body habitus, to learn to interact with difficult patients and all that stuff. Again, I think that is an argument of convenience, right? We can simulate difficult patients. We can teach in a way that will help the learners troubleshoot. And I'm going to come back to this concept, but I just want to remind you of what Mike talked about earlier on how to Mike, what did you say? Like how to move the probe so that the image gets better? What is the term that you use?
I more so described it in there, but it's the idea that you can use a lot of cognitive modeling to have people talk through how they would get there. So
Right.
instead of,
Right, so that's essentially, you need to know how to troubleshoot, and you have to troubleshoot whether because they need to do a parasternal loan, but then they have to navigate through all the EKG leads and defibrillator pads, or, whether because they have a burned chest or because they have a crepitus or whatnot. I mean, it's how do you troubleshoot? And you don't necessarily need real patience, I think, to do that. And these are just my questions and my thoughts. And, I want you guys to think about that when we think about educational scans. I feel like it's one area that we really need to look at. So then for me, the issue with this is more about protecting the patient, which I don't think I do enough of when I let all my hordes of learners go, like, descend onto like the bored ED patients. So the other people that we have to protect are the learners, right? There is no guideline, right? Like CDC is telling me that my kid, 8-year-old, can now go into elementary school 3 feet apart from another student, but 6 feet apart from his teacher. Like, it's, there's no guideline for us about learners. So like, how far apart should the learners be apart from each other? Should we think about how much air they're breathing and breathing out, breathing in and out, how much aerosolization are they doing and all that stuff? So should we have a maximum number of learners per square footage of the patient room? What kind of PPE should be standardized for them to be wearing moving forward? I certainly cannot envision that people don't wear masks anymore, right? So talking about education scans and learner protection, these are really about protecting patients and protecting the learners. Now talking about education. So what is the educational environment that's really optimal for education? Let's just say for scanning period, right? So because scanning is still gonna be like the problem. That's the problem. We wanna teach people how to scan. We cannot replace that with virtual period, like complete virtual, at least not right now. So like, what is the best educational environment? People toss around things like 4 students to 1 instructor, right? People say that a lot. What about like, do you need, what is it, is that by extension for students to 1 model? I mean, we have to think about in terms of protecting the patient and the learner, and also allowing them to learn maximally. Like, how many students should we be allowed in a room, right? What is the best educational environment for that? And assessment models. Okay, so now we got all these like, asynchronous stuff. We got simulators. So previously currently we have all these guidelines. We need 25 scans to be certified for this one exam indication. We need 50. What if they didn't do 25 fast exams? They did 5, but then they went through 20 sim scenarios. Does that count? Do sim cases count toward their assessment? What about portfolios? Can the hours they log with these asynchronous or sim or some other like AR, VR, would they count toward their portfolio? And we really have to think about what we want to do about that going forward. And I'm telling all of you guys, because you guys are the educators who are interested in this, and I think we need to put forth like new guidelines and do research to answer these questions. Next slide. A lot of the answers might be in more technology, right? So here's a video of virtual reality. So this kind of thing doesn't exist for POCUS yet, but this is an orthopedics, right? So they have a simulated patient. This is your learner. They put on, you know, they hold on to these handles. They might be putting on an Oculus 2, and then they can manipulate. They can work with another person. They can manipulate these hardwares, right? And you can do this to simulate ultrasound guided central line. You're drilling in, right? This is orthopedics, obviously. And look at that. The learner is turning the knobs on the left-hand side. They're actually rotating the knobs, right? And then next one. Oh, next slide. Yeah, this is an augmented reality. Go ahead, play. So on the right upper side, you can see the learner, right, carrying everything, and he's picking up the stethoscope, he's auscultating the baby, and you can actually hear it. And on the right lower side, you can see a log of what's happening in the scenario that the learner's going through. He's palpating for pulse and checking the clock to see if the baby is tachycardic, right? And the baby is still crying. I mean, we're not putting on the audio right now. So then what does he do next? He goes and try to appease the patient, and the baby, you know, rubbing the head quiets the baby and all that stuff. So there's so much that we can do now with virtual reality and augmented reality. So more technology to come. And I think this is gonna go to POCUS as well. Next slide. I'm going to expand beyond just the pandemic a little bit. So, you know, the society is changing. Our medical practice is changing. More and more care is going to be practiced outside of the hospital. I'm doing peer review on articles about admitting to home hospitals. Pre-hospital time is getting longer and longer. What does that mean about POCUS? And what kind of POCUS are we teaching our residents to prepare for them when they graduate, for the world when they graduate, not right now, for the world when they graduate, for their career? What kind of POCUS are we teaching our students for when they graduate, right? So what I think we need to shift our focus really into telling them how to coach either patients themselves or providers that might not be MDs, might be patients themselves, maybe patients' family or other people who might have access to machine, but don't have access to 4 years of medical school educations and another 3-4 years of residency. So going back to what Mike started, you need to be able to coach another person by saying, okay, now you have to rock to the left or rock laterally. You have to translate superiorly. That means toward the head. You need to push down harder or to displace the bowel gas or try to squeeze out the subacute emphysema to get a better window. Why not? We need to focus on a different aspect of the teaching that we have traditionally been doing, which is like, okay, go learn how to do a FAST exam yourself. Maybe we need to do less of that, but more of how you can coach another person to get to the right image. Right? I'm just speculating. I'm not saying that this is exactly what's going to happen, but there's going to be increased teleguidance. What about technology? What if, like, in the future, all the ultrasound are going to be acquired with 3D data? I mean, that's very foreseeable, right? So, and what if, like, you know, the ultrasound is now going to be wearable? Right? What if a patient just go put on a vest and then they'll get their thorax ultrasounded in 3D? What are you gonna do with that? And about AI, you know, it's kind of like we have a proliferation of foam before we figure out how to evaluate them and assess them and figure out what to use and what not to use. How do we evaluate AI technology, when to use it, when to trust it, when to override, with going back to using our gray cells, you know? So these are maybe more of the education that we need to now focus on. Finally, on education, Mike already touched, Elaine gave us a lot of good tools and talk about how we assess them, right? How do we assess the foam? So we need to continue to do that. And then we need to think about whether people are just reading 144 characters of learning, how do we deepen that? How do we go from like a very superficial surface glance and you can read 100 tweets in 2 hours, or actually does Twitter allow a deep dive into one particular topic or not? We have to think about these changing practices outside of pandemic, and we need to adapt to that. So a lot of questions. Sorry, no answer from yours truly. But I think these are things that we have to start investigating in order to be prepared for the future. And with that, we can take some comments, get some discussions going, and hopefully answer some questions.
I'm just scanning the chat for you right now to see if there's any specific questions. A lot of compliments, by the way. The three of you make an amazing team. And I was constantly having my phone up to the screen doing all those QR codes, which were incredibly helpful. Let's see. One says, I can't open the student finish. Let's see. There's just some little comments and any questions. I was curious, how are you, because a lot of this seems geared toward your rotators. How are you teaching the upper levels in this pandemic? Because I was just wondering, I mean, their skills kind of decline if they're not frequently using it. I was just wondering if you have any advice on how you are reaching out to them.
So I'm gonna start, and anybody else feel free to jump in. But I actually think that the upper levels, we should encourage them to do more clinically related. We talk about how pure educational scans really does not teach clinical reasoning or choosing of imaging. But the upper levels, as they are doing their clinical practice, they might be able to, how should I describe it, lower the bar to do an clinical exam. So this clinical exam will be having educational flavors to it, maybe, right? So should everyone come in with a right upper quadrant and epigastric pain, get a right upper quadrant gallbladder scan? I mean, in my patient population, it's actually indicated because we just have such high prevalence, but maybe not in everybody's patient population, but that wouldn't be a reach. And I think it actually helps teach the residents clinical thinking if they do, just like, in a teaching hospital, sometimes we order more x-rays and more CTs because the residents do need to learn how to figure out what tests to order and how to confirm or rule out their pre-test probability. Anyone else?
I think that's a great point, is thinking about the higher order thinking, how we can bring it up a level. Building on Mike Seiko's comment too about that, there's a certain point, it's hard to engage a large number of learners without some of them going to their phone to do something else. So typically we work in Russian groups of 3. And so that with that 3, how do you keep everyone engaged? I just assign roles. So oftentimes, we alternate with either the senior doing one scan where they would show how to do it, and they'd be like, here's how I got here, here's how I troubleshoot it. And the other one walking through the junior and kind of helping them with that mental modeling. Like, I see you're angled like this, here's how I adjust that. And then the third learner who rotates in that will often have like a role of looking something up. So I might say like, okay, as we're going through this, because I don't want to tax, and we think about cognitive load theory, I don't want to tax this person who's trying to get a good image while they're trying to do a technical piece to also say, by the way, what's the threshold of gallbladder wall thickness? And what's the CVD threshold? And when does age adjustment matter? And that's just, it's too much to remember at one time, which means they remember nothing. So rather, while they're working on the technical piece, the one who's the third learner is looking up an image, or I might say like, all right, how about you tell me what's the threshold for this? And if you don't, show me how you're going to look it up. And then I engage them a different way to bring exactly as you brought up that higher order thinking, so that everyone in the room is focusing on different pieces at different time. Interested to see kind of, Elaine, what you do too.
Yeah, for me, we do rotations as an intern, and then second or third years, they could come back and do a selective if they want to, but really it's on shift teaching. It's really being able to apply point of care ultrasound in places that they're gonna find interesting. So I find myself needing to sell POCUS to them a little bit, because I always see this change in interest. When you're an intern, you're super into point of care ultrasound, right? You're learning a new skill. It's so cool. You see cool things. And then junior year, you start being the workhorse of the ED. So, oh, I'm too busy to pull the machine in the room and take a look at things and do images. And then third year comes around and they realize, oh shoot, in less than a year, I have to do this by myself. And so I am noticing, especially around this time, that seniors who are going out to the community are asking me, oh, Elaine, what should I do for ultrasound? Should I get a butterfly? Should I get a V scan? I just want to be able to do those core applications. And we just consider that, you know, ordering a radiology study is going to take a minimum 2, 3, 4 hours, depending on how busy the ED is and how busy each step of the way will take you. Whereas point of care ultrasound, you're going to pull the machine in. Yeah, it'll take 5 minutes to do that, but then within 10 minutes, you'll be able to answer your question, answer that clinical question. So I find myself needing to remind them the benefits of point of care ultrasound.
I just want to also comment on one of the topics that was generated in the chat about having the rotators be involved as consulting team in order to bring that clinical integration in. I just wrote that, please be careful about that. Make sure the primary team resident has to do the scan. I make them do the scan with the rotators. The rotators can set up the machine, clean the machine for them, but they have to do, because the last thing you want to do is essentially have the primary team say, hey, ultrasound rotators, can you go do that right upper quadrant for me? Because then they become radiologists, right? They become radiologists that actually come in to the bedside and do your scan for you, which is not the spirit of POCUS.
Very good feedback. Just bring it back to the clinical arena and how it's very helpful in keeping everybody engaged. Anyway, I think we're out of time. Just wanted to thank all of you for listening and joining us, and our presenters. That was amazing. I literally think it was one of the best SAM presentations I've had in a long time. So thank you all.